In this session, we're going to cover some of the strategies for metastatic renal cell carcinoma that involve IO therapies in combination with VEGF-targeted therapies. I want to talk a little bit about some of the trial designs and some of the endpoints, and to kind of walk us through some of, really, I think a series of ongoing studies now, both at sort of the phase 1 all the way to phase 3 levels. Toni, can you kind of summarize this field where we are?
You know, after checkpoint, checkmate 214 with Nivo Ipi, and currently we have not published yet, presented Emotion 151, VEGF ligand inhibitor bevacizumab plus PD-L1 inhibitor atezolizumab versus sunitinib. Again, primary endpoint was met, waiting for the overall survival endpoint, although there are some discrepancies whether you look at progression-free survival by independent review or investigator review. So that's another, 2 out of 2 are now positive. What's gonna come the next few years, and perhaps less, is other PD-1, PD-L1 inhibitor in combination with VEGF TKI. Rather than the VEGF ligand inhibitor bevacizumab, and all against sunitinib. So pembrolizumab is being combined in 2 trials, one with lenvatinib, and the other one with axitinib, frontline against sunitinib, with different endpoints, sometimes progression-free survival, overall survival, co-primary endpoint. They're all supposed, to read in the next few months to years. There's another study that compares cabozantinib plus nivolumab versus called 9ER versus sunitinib. Same thing. And we have some studies, planned in the alliance with you and Mike and Tian.
Yes. So Walt, some of these IOs plus VEGF or VEGF TKI studies are looking at progression-free survival as an endpoint. What do you think about that when you think about these patients that we really anticipate treating with a series of sequential therapies? Is that going to be a strong enough endpoint? Or are we going to need to see overall survival in these studies?
I think that in the context of Ipi-Nivo showing a true survival advantage, I think that these trials have to show a survival advantage in order to be practice changing, especially in the frontline setting where many of these trials are being done. When they were designed, progression-free survival was considered to be an appropriate intermediate endpoint, and there's some data that is. But I think in the context of this new data, it's just not good enough. And Toni already brings up the fact that in the atezolizumab, bevacizumab trial, that the primary endpoint of investigator-assessed progression-free survival was positive, but centrally reviewed progression-free survival was not positive. And so I think we're going to have to see what the survival data shows in order to try to interpret that. Likewise, I think with the other studies, we're really going to have to see that. And I think that since the control arm is sunitinib, since we have this goofy FDA mandated drug schedule of 4 on, 2 off, and not all patients can tolerate that, and then goofy drug modification and dose reductions in those trials, this really sort of leads to that control arm being, everybody's favorite whipping boy, because it appears to be the easiest thing to beat, as well as being the, quote, standard of care. So in that context of all these issues, I do believe that survival has to be the endpoint.
And this was brought up earlier with Ipi-Nivo, that there's a concern about the balancing the efficacy versus the toxicity. Rich, do you have a sense of the toxicity that we're seeing, at least from the Emotion 151 and maybe from the early phase 1 studies with these combinations of IO and VEGF
Sure.
TKI?
Yeah, I think it's first important to comment on the overall grade 3-4 toxicities of, say, even checkpoints versus sunitinib. I think sometimes the checkpoints get a worse rap, but when you look at the total grade 3-4 AEs, there's really not much of a difference, and perhaps even less in the total grade 3-4. But there is more of a need to stop IOs. I think treatment discontinuations is higher in that. So I think there is a lot about how you want to think about AEs, whether it's grade 3/4 versus discontinuation. In regards to atezo and bev, I think it is probably of the combinations one of the most well-tolerated study combinations, and I think that's being presented here as well with the quality of life. So I think when you're thinking about quality of life, and especially in a patient maybe with poor performance status who may be elderly and that's quality is more important, that might be one of the more ideal regimens.
Tony, your thoughts
Yeah,
on these
no,
combinations?
I do agree. I think it's, overall survival going to be driving, a lot of these decisions, what to use. I agree with Walt. But also there are trials where, the primary endpoint is also powered in PD-L1 positive patient. And I can tell you that that's actually very smart and very interesting. Why is that? Because we know well from data we worked on with COMPARES and others that PD-L1 positive patients do not do well at all with sunitinib. If you look at their median PFS, it's similar to the Cabo-Sun study. I mean, they don't do. So could we have a significant PFS advantage that will translate in OS with a certain combination, VEGF-IO, to select patients?
And Tony, how are we going to use their PD-L1 marker was very different than anyone
Absolutely.
else's. So now when you send your tumor, are you going to send it for 3 different PD-L1s?
Well, hopefully with the combination, the compendium use of the
But maybe you want to pick from all 3 different regimens. I mean, how,
right,
you
but
know?
I assume with, let's say, avelumab axitinib, which is an active combination, if this prove in PD-L1 positive to be really significantly superior, and it could be that patient don't do well with sunitinib here, then hopefully we'll have the compendium biomarker from that trial. Sure. But I want to add, one of the issues we're going to have is how to manage side effects, and I want to give one example that illustrate my challenges here when I have patient on a VEGF TKI IO is the diarrhea. Yeah. Because diarrhea is a side effects that could be from IO, with a colitis. The treatment is very different than a diarrhea, which is very common with all VEGF TKI from something else. And sometimes you cannot tell, and it's really challenging. I usually start by stopping the TKI, observing the patient very closely. And the other one that is less common is the hepatitis. A hepatitis grade 1, 2 due to the TKI compared to a brewing or immune-related autoimmune hepatitis from checkpoint blockers is very different.
Yeah. Yeah. No, I think that's a great point, and I think it's really important to recognize that there could be some synergy, not just on the efficacy side, but also on the toxicity side. And the phase 1 studies may not show it, and we may be fooled a little bit by atezo-bev, because that's a better tolerated VEGF strategy. With these TKIs, we may end up seeing a little bit more of this. So I think it is an important issue to look for.